Hello, my name is David Schwartzide, and it's a great pleasure to speak to you today regarding implant support over dentures as part of the Mentorship Implant Training Program. Implant support over dentures are removable prostheses that stay in place and attach to the implants that are embedded in the bone, and they attach a little bit like the clips on the jeans. That's a fine, easy way to explain to patients what they are. Implant support over dentures have a number of advantages. First and foremost, they're very successful. They're much more successful than conventional prostheses. In fact, it is often stated that they should be the first treatment option that should be offered to patients who are edentulous or are about to become edentulous. They are more cost-effective and certainly less invasive than some of the fixed treatment modalities that are also very successful. And implant support over dentures are very versatile. Essentially, within limits, pretty much any number or distribution of implants can be used or utilized for the purpose of implant support over dentures. I think we can all agree that when it comes to fixed implant support prostheses, that is certainly not the case. To give an example, if I have 3 implants on the right-hand side and nothing on the left, we certainly cannot use that for a fixed implant support prosthesis. But for an implant support over denture, we certainly could. There are sometimes situations where a fixed removal prosthesis is no longer working for the patient, either because they cannot adapt to it or because of a failure or loss of some implants. And for these patients, an implant support over denture is also a very acceptable treatment modality. I'd like us to focus today specifically on mandibular implant support over dentures. There are a number of principles or designs that we would utilize for mandibular implant support over dentures. First and foremost, we typically utilize 2 implants. We can certainly use more than 2 implants, but 2 implants is more than plenty. There are many attachment mechanisms that can be purchased and utilized to help retain the over dentures in place. But by far the most common attachment mechanism is called locator. Abutment locator is a brand. And the reason that they are utilized is they're quite short, which is important because often the space can be limiting, and they're easy to adjust and modify over time. In the past, we've often also utilized various types of bars to connect the implants. So we would say that the implants are splinted. That is really completely unnecessary, and the bars are quite expensive. So nowadays, by and large, we say we utilize individual unsplinted attachments. The use of locator attachments comes along with a number of tools that you and I can utilize in the fabrication process, and we'll go through these tools one by one. We have the impression copings, which look a little bit like upside down wine glass. We would utilize these impression copings to take the impression of the locator abutments that have already been inserted in the patient's mouth. We have the analogs, sometimes referred to as female analogs, and these are the analogs or the copies of the abutments that are present in the patient's mouth to be present in the master cast of the patient. We have the males or the inserts, and these sit inside the removable prosthesis and then clip on to the abutment in the patient's mouth. And these are designed to be the weakest link. They're the ones that wear down over time, and they're the ones that we would replace on a somewhat regular basis. There is a locator abutment tool, which is used to both secure the abutment as well as insert and remove the inserts. And last but not least, we have a latch type locator driver, which we can also use to insert or remove the abutment. I'd like to expand a little bit more on the locator core tool. It comes in 3 segments that are then connected together, and each of these tools is used for a specific purpose. One end of the tool is used to engage an insert that's already sitting inside the abutment and to remove it. Another end of the tool is used to insert the male insert inside the prosthesis. And the gold colored tool is what's used to insert or remove the abutment from the patient's mouth. This tool comes in a variety of designs, or has come in a variety of designs over time. And one of the designs that was quite popular in the past has a bit of a curve or a hook to it that I'm showing here. And I'm just showing this here for completeness because you may come in contact with this version of the tool as well. This hook is what's used as an alternative to remove the insert in the prosthesis. The inserts, retentive inserts, sometimes also called males, come in a variety of retentions. And incidentally, this ability to modify the amount of retention is one of the great advantages of a prosthesis, because we need the patient, on the one hand, to be able to insert and remove the prosthesis. On the other hand, we need the prosthesis to stay in place. And sometimes there is a conflict between those two. A person may want their retention to be quite high for their comfort, but if they're not able to insert and remove the prosthesis, that's not going to work. And it's responsibility for you and I to try to find a solution to an individual patient where there's just the right balance between their comfort with retention and at the same time their ability to insert and remove the prosthesis. The colors are standard. You don't need to memorize the colors because these are available freely as a guide you can look at on the internet. What is important is these inserts come in two different styles. There are what are called conventional inserts, which you see on the left side of the screen, the three of them, in blue, pink, and clear. And then the 5 inserts, what are called extended range. And what these are designed is to account for a larger divergence of implants that we occasionally encounter. Either one, it can be completely appropriate to be utilized, although in general nowadays, I think I would recommend the use of the extended range insert just on a routine basis. Again, a locator abutment is the part that sits inside the patient's jaw, and its equivalent or counterpart is the denture cap, which is what sits inside the removable prosthesis, and the two of them connect. And this diagram here illustrates the connection of the two of them, and it inserts the blue insert and its position. And you'll notice that the blue insert is both enveloping the yellow abutment as well as sort of engaging the inner portion of the abutment. And it is this engagement of the inner portion which is what separates conventional inserts from extended range. Extended range inserts don't engage the inner core. They don't engage the inner core so that to allow for greater variation of angulation, but incidentally, this has a side benefit in that sometimes food gets caught in the small gold receptacle of the abutment. And if that is the case, then sometimes patients cannot insert the removable prosthesis with conventional inserts until that area is cleaned out. Because extended range inserts don't engage that particular area, it's irrelevant if sometimes food gets caught in that area. The other thing to remember is that everything that sits above the soft tissues is, one sense of the word, universal. That means when the patient presents to you with the locator abutment already in place, it's irrelevant what's the company that produced the implants. Just knowing we have a locator abutment in place, we can now go ahead and purchase components or utilize components from any implant brand. That's why they're universal. The only part of this assembly that is implant brand specific is the actual abutment that is utilized. And in fact, it's not only the entire abutment, but it's the portion that fits inside the implant. Locator abutment come in a variety of heights to account for variations in soft tissue height and sometimes some clinical needs. One of the important decisions that you need to make when you are restoring a patient with locator abutments is making a decision regarding the height of the locator abutment that's going to be utilized. And this is a balance. A lot of things in prosthodontics are a balance. The balance is if the abutment is chosen too short, then it will interfere, the soft tissue may overgrow it, and it may cause soft tissue irritation. The prosthesis may cause soft tissue irritation. By contrast, if the abutment is chosen too tall, then this will weaken the prosthesis and may cause a predisposer to fracture. So when the patient presents to your office, what you need to do is remove the healing abutment, make a note of the height of the healing abutment, and then measure the soft tissue height, and then select the tallest or the thickest soft tissue height, and then round it up to the whole number. That should be the minimum abutment, locator abutment height that is selected or chosen. And in these images here, you can see how important it is to select the abutment of the appropriate height so that the denture cap that sits over it does not interfere with the soft tissues. One thing to keep in mind is that healing abutment height can be measured directly. If you have a healing abutment in your hand and you're not sure what its height is, you can literally take a ruler and measure it. A locator abutment is always going to be about 1.5 millimeters taller than the actual listed abutment height, because again, there has to be a denture cap that sits over it. And this sometimes causes a little bit of confusion when it comes to patients presenting with particular heights of the healing abutments. Let's review a little bit the overall sequence of overdenture treatment, specifically focusing on mandibular implants for overdenture treatment. Well, of course, everything begins with some assessment, treatment planning, optimizing existing prosthesis. There is a surgical procedure of some description that's going to be preceded by fabrication of a surgical guide. This is going to be followed by healing process, followed by fabrication of an overdenture, either a brand new overdenture or conversion of existing prosthesis. And this is going to be followed by maintenance. This is not a surgically focused lecture, but I feel it is important to have some sense of what are some of the surgical parameters that are critical to the overall treatment success. Well, one of these is want the implants that are positioned to be relatively symmetrical across the midline. The reason we want that is for ultimate patient comfort. This is both when the prostheses are in place and when they're not in place. When the prostheses are not in the patient's mouth, if the two implants are not symmetrically distributed, the patient will perceive the difference between left and right, and patients often don't like that in their mouth. When the prosthesis is in place, then if there's significant difference anterior-posterior between implant position, the implant that is close to the midline will have a larger lever arm, and the patient will perceive that side as having a greater degree of movement. Again, patients don't like that. So one of the things we want is implants to be positioned relatively evenly across the midline. The other parameter we want implants to be relatively parallel to each other, relatively parallel to the path of insertion, and relatively perpendicular to the plane of occlusion. The reason we want that is because if we don't follow these parameters, then on the one hand, the patient may have a difficulty inserting and removing the prosthesis. And on the other hand, there may be a challenge with increased potential for wear and therefore need for replacement of the inserts as well as of the abutments. Last but not least important parameter is we want the implants to sit typically roughly in a lateral inside a /canine position. The reason we want that is on the one hand, that is to permit further treatment evolution to a fixed prosthesis. Why is that? Because we want there to be sufficient space that's mesial to the mental foramina, but distal to the implants to potentially place a new set of implants and then transition to a fixed prosthesis. On the other hand, if the implants are too close together, then they almost act like a single implant. What we don't want happening is an example here. We can ignore the maxillary arch, focusing on the mandibular arch, and we can see that on the right-hand side, although the implant is not literally very close to the mental foramen, it's close enough to make it essentially impossible or very difficult to safely insert another implant in between the existing implant and the mental foramen. This is what we're trying to avoid. Again, if the implants are too close together, then they begin to act almost like a single implant or individual attachment, which we don't want. By contrast, if the implants are too far posteriorly, in addition to the concern I've already mentioned with there being difficulty converting to fixed prosthesis, we're also then incurring an unnecessary surgical risk by manipulating soft tissues in proximity to the mental foramen. There are two general prosthodontic approaches to transitioning from an existing prosthesis, from a prosthesis, to an overdenture. We could make a brand new prosthesis, or we could convert and modify the existing conventional denture into an implant support overdenture. And I'll discuss both approaches, and I'll go through each of them sort of in the pictorial fashion, and then with a little bit more key points thrown in. So if you and I are fabricating a brand new mandibular implant for overdenture, how would we do? Well, of course, we would check to make sure the implants are osseointegrated. We'd fabricate a custom tray. We would seat the abutments in the patient's mouth. Then we would seat the impression coping onto those abutments. And then we would take an impression of the ridges in a manner very similar to the impression for a conventional complete denture. We would then pour a master cast. Would then fabricate a base plate and a wax occlusal rim on the master cast. We would try that in the patient's mouth, obtain an intraocclusal record, including securing the VDO, establishing the midline, selecting tooth shade. Then we would do a tooth try-in, which of course confirms the appropriateness of the intraocclusal record we obtained previously. And provided that everything is good, we then have our prosthesis fabricated, and we insert it in the patient's mouth. Now let's go through these steps in a little bit more detail. Again, first we have to take a preliminary impression so we can create a custom tray. Once we have a custom tray, we will select and insert the appropriate locator abutments. That will involve removing the existing healing abutments, measuring the greatest soft tissue thickness, rounding it to a whole number, and then selecting locator abutment that's at least that amount. We'll then insert the locator abutment, we torque it into place. Then we insert the impression copings onto locator abutments. These are these gray upside down impression cups. We take a final impression as well as, of course, taking a final impression of the opposing arch. The laboratory will then return to us a base plate with a wax occlusal rim. You would try in the base with a wax occlusal rim and establish neutral zone, VDO, lip support, midline, etc. Obtain intraocclusal record. You would select the tooth shade and tooth mold as with any other case. The case would then come back to you. You would check the aesthetics. You would check the occlusion. And provided everything is fine, the case will go back to the lab. The lab will process the prosthesis and they'll return the prosthesis to you for insertion. One important element here is we always want to try in the prosthesis and insert it with the lowest amount of retention. And that typically means inserting what are called black processing nails. They have very limited amount of retention, but it's usually sufficient retention for the first few days or couple of weeks while the patient's becoming accustomed to the prosthesis. They would then be switched over to something of a greater retention. But again, we would always advise to start off with the least amount of retention. And in this case, the blue is what works for the vast majority of patients. Once a prosthesis has been inserted, you would see the patient for follow-ups as needed to make the various adjustments for removal prosthesis, as would always be the case, which is followed by regular maintenance roughly on a yearly basis. So that was a description of how you would manage a patient when you're fabricating a brand new prosthesis. And in many ways, it's very similar or identical to how you would fabricate a conventional removal prosthesis.